Hi, everyone. My name is Yvonne Yang. I'm a psychiatrist and a researcher. Thank you so much to the organizers of the Law and Mental Health Conference for inviting me to be part of this wonderful conference and wonderful group of presenters. So today I see my goals as several-fold. To give you some context as a clinician about psychosis and what it's like to treat individuals who experience psychosis. And I am going to spend a little bit of extra time on medications specifically, hence the title of my talk, The State of Treatment of Psychosis, Pharmacological and Interventional Therapies. So briefly, I am a psychiatrist and a researcher with most of my clinical and research work being focused on psychotic spectrum disorders. I have been California and UCLA based since beginning residency. And most of my clinical practice is at UCLA and the Veterans Affairs Healthcare system in West Los Angeles. I also teach extensively at both the UCLA and VA psychiatry residency programs. And I have no disclosures to report. So as I mentioned, I'd like to just spend one slide on clinical context for psychotic disorders, and also some context for why medication is important when we talk about this set of illnesses. And I'll talk about medications. And again, within a 30-minute presentation, it's difficult to get really in depth into psychopharmacology, but I am especially going to talk a little bit about future modes of treatment and future medications that are in the pipeline. All right, to start out with, what is psychosis? Dr. Applebaum provided a really nice summary of what psychosis is as defined by the DSM-5 TR. But I wanted to share and fill in a little bit more than just these diagnostic criteria from a clinician's standpoint. As Dr. Applebaum said, it is a disconnection from reality, or sometimes and oftentimes I think of it as an individual experiencing a reality different from those that somebody else might be experiencing. As is commonly understood, sensory hallucinations, including hearing voices, thought disorders such as disorganized thoughts, and delusions, including paranoia, are hallmark features of schizophrenia. However, there is more to it than that, and I feel like this sometimes gets left out when we talk about illnesses like schizophrenia, which is that oftentimes there's actually a sense of weakening of the boundary between the self and the outside, the other. And one manifestation of that might be something called thought insertion, where people believe they can hear other people's thoughts in their minds, or thought broadcasting, where they believe other people can hear their own thoughts. Oftentimes, there's also sometimes a greater sense of meaning in the world, a sense of understanding of a meaning beyond oneself, which is quite remarkable. I also want to highlight that experiences of psychosis differ from person to person and even culture to culture. There's a large body of literature that shows that what we regard in the United States as something that's highly stigmatized and very worrisome and problematic and requiring treatment can be welcomed in other cultures and have alternative interpretations and understandings, including spiritual, religious, related to kinship, ancestry, and so on. And of course, from person to person, the term schizophrenia and the term psychosis spectrum disorder is not linear at all. And oftentimes the manifestation in one individual can look completely different from that in another individual, to the point where they're non-overlapping. And this adds to the complexity that we encounter when trying to help people who are experiencing psychosis. So if we're talking about the intersection between law and mental health, why would we talk about medications having to do with psychosis? And I realize, thinking about my experiences as a clinician, both as an inpatient psychiatrist and an outpatient psychiatrist, that medications form the crux of a lot of the dynamic between mental health and the law when it comes to individuals with psychosis. Concepts like capacity and involuntary hospitalization and anosognosia all kind of revolve around a fundamental tension between autonomy and safety. And what I want to sort of say about medications and where it belongs in that conversation is that Again, as I mentioned, differences among individuals experiencing psychosis, not every single person has to have medications in order to get better, but there is at least a subset who are very unlikely to get better unless they try medications. And for many people, medications remains our best option. And for some people, their only option when it comes to getting better. So I think that this tension between autonomy versus safety really plays out a lot when it comes to medication. For instance, can we compel somebody who doesn't have capacity to make medical decisions due to their illness to take a medication? When can we hospitalize somebody against their will in order to help them and get them on the medication? Right. So in the case of involuntary hospitalization, we're prioritizing autonomy, we're prioritizing safety of both the individual and society over an individual's autonomy in order to provide them with medication that will hopefully help them feel better. Really significantly, anosognosia literally translates to lack of awareness of illness, of disease. And this is an interesting term. It refers to the fact that many patients with psychotic disorders not only might not be aware that they're ill, but actually firmly believe that they're fine, that they're not ill at all. And that can be a tremendous problem when it comes to wanting to help people get better. As I was saying, other questions about law and mental health when it comes to medications includes, can I compel somebody who is an outpatient, not involuntarily hospitalized, to take a medication? Can I compel somebody to take a medication in the form of an injection? Can I compel somebody to be in mental health treatment in general? And these are debates that are going on all over the country. And the rules and policies differ and laws differ from state to state and even county to county. Okay, but to get to the topic at hand, which is medications, I share this slide because as a psychiatrist, a lot of psychiatrists, for us, it's really all about the brain, and especially a biologist like myself, mental illness resides in the brain and the treatment must apply to the brain as well. I do want to acknowledge that the brain is inside a person, the person is part of a community, and that community is part of systems. And just like I was saying earlier, how the experience of psychosis is affected by somebody's culture and environment, there's a whole community of treatments available outside of psychopharmacology and interventional therapies that I'm going to talk about today. Those include all manner of talk therapy, cognitive behavioral therapy for psychosis, movements including the hearing voices movement, other movements working to destigmatize the idea of having psychosis. I think all of those are really important, and we can and all should work together. Okay. So, pharmacological treatment of psychotic symptoms. This is the first of three brief topics that I will discuss. So in terms of the timeline of antipsychotic development, the first generation antipsychotics, which include medications that may be familiar sounding to you, like Haldol and Thorazine, were introduced in the 1960s. They were termed neuroleptics and tranquilizers. They were originally designed to help with anxiety and agitation, but it turned out that they also helped reduce symptoms like hallucinations and delusions over time. These medications, of course, have significant side effects associated with them. And it was an exciting time when second generation antipsychotic medications came around. The first one was clozapine. And you may be familiar with many of the more recent second generation medications, including risperidone, olanzapine, and quetiapine, all of which are used extensively for psychotic disorders. Clozapine may not be as familiar sounding to those of you who know some of these medications because it continues to be very much underutilized, especially in the United States. I'll talk in a little bit about how it actually remains, according to almost all the evidence available, the best antipsychotic that we do have on the market. And yet very few people are on it because of a set of regulations and sort of regulatory monitoring surrounding it due to side effects that are associated with it. In the 2000s, the quote unquote third generation of antipsychotic medications, including aripiprazole, were introduced. Others in this category include brexpiprazole, its very close cousin, cariprazine, lumateperone, and pimavanserin. And what makes these I didn't really explain the generations. So I do want to mention every single one of these medications, except for lumateperone and pimavanserin, to have their action on the dopamine receptor. And I didn't think I would have time to talk much about neurotransmitter systems, but of course, neurotransmitters are how neurons talk to each other in the brain, and dopamine is a really important one for the reward system. And it turns out that when we block dopamine receptors, we can help reduce some psychotic symptoms. So first generation antipsychotics all bound the dopamine receptor and pretty, not exclusively, but with fair amount of fidelity. Second generation antipsychotics bind dopamine receptors, but they also bind other receptors like serotonergic receptors, which helps with their tolerability. Third generation antipsychotics are slightly different. So for instance, aripiprazole and brexpiprazole and cariprazine bind dopamine receptors, but they either bind as a partial agonist or they bind a slightly different receptor than the first generations. They bind D3 receptors instead of D2. And lumateperone and pimavanserin actually just bind entirely different targets, such as serotonin. There continues to be a tremendous amount of research with regards to medications for psychosis, because our current medication options, even though we're now in the quote unquote third generation, still leave a lot to be desired. In terms of efficacy, I think the rule of thirds is an easy way to remember that about a third of patients experiencing psychosis will remit completely on an antipsychotic. Another third will remit partially, so they'll have some improvement, but still have residual symptoms, which will have varying degrees of effects on their lives. And then another third really won't improve at all. And if you think about that in terms of scoring well on a test, nobody would call that doing well, right? And certainly we would want many more than 1/3 of patients experiencing psychosis to have complete remission. Also, I haven't talked too much about different categories of symptoms. Hallucinations and delusions are regarded as quote unquote positive symptoms, but then negative symptoms are the sort of more social withdrawal and decreased expressiveness types of symptoms of psychosis. And these medications are largely ineffective for those. And then cognition, meaning sort of cognition is like executive function, memory, processing speed, language, everything that we use to kind of get through the day is really oftentimes impaired in psychotic disorders. And these medications either don't help or sometimes can even make cognition worse. So there are some new medications coming down the pipeline. And when I say non-dopaminergic, what I mean is these are medications that all of which act on a different neurotransmitter than the dopamine neurotransmitter system, which almost all of the ones I've already mentioned act on. And I'm going to put up a list of 5 exciting medications. They are very near unpronounceable, and I don't put these up to confuse anybody, but I put them up because they're exciting. They're coming up the pipeline, and this is certainly the most. This is a very abbreviated list of those that are actually like in the clinical trials process, but these are some of the most exciting. And the target systems are the muscarinic receptors, TAR1, which is a trace amine associated receptor, glutamate systems, serotonin systems, and glycine, which is a coagonist for the NMDA receptor, which is also glutamatergic. So to me, this list actually brings me a lot of hope and excitement because for literally decades, we've only had medications that worked on the dopamine system. And we know that dopamine alone doesn't explain all of what happens when somebody becomes psychotic, and certainly targeting that system has been insufficient to provide wellness and health for a majority of patients. So I have two small case studies to discuss about medications and psychiatry in the law. And they have to do with two of our most effective medications, one of which is clozapine, which I've mentioned before, and the other of which is this class of medications called long-acting injectables. We shorten that term to LAIs quite often. So in the case of clozapine, I mentioned this already. So clozapine has a unique side effect in that when it was first released on the market and first being studied, there were some unexpected fatalities, and it turned out that people's white blood cell counts were dropping really profoundly. It turns out that this, just by having a regular blood draw, you can prevent any sort of danger from the drug. And so different countries implemented different REMS strategies, so risk evaluation and mitigation strategy policies. The REMS program is run by the FDA. Other medications have REMS policies as well, not just clozapine. And but as a result of the REMS program, people in the United States, for instance, can only get clozapine if they get their blood drawn every week for the first 6 months of being on the medication, every 2 weeks for the next 6 months, and then every month for the rest of their lives. And through this program, there have been almost, I mean, just literally the risk is zero of dying from agranulocytosis being on this medication. However, many prescribers perceive the medication as either a really serious bureaucratic hassle or even potentially just dangerous due to its side effects. So if we look at other countries, many countries have more lenient monitoring schedules. And I actually just did an analysis and just had our paper accepted showing that in countries that are more individualistic, the clozapine monitoring system is more stringent. In other words, it seems like the system is designed to protect the individual, but who suffers as a result is the greater number of people who could be benefiting from being on clozapine, but who aren't on it because of the restrictive policies. With regards to LAI medications, long-acting injectable medications, long-acting injectables are really great. So imagine that you take a blood pressure medication every day and you forget every once in a while. And so on some days, your blood pressure is higher than it should be. The same thing happens with antipsychotic medication. And even more than that, plenty of patients don't want to take their medications or don't believe they need them. So long-acting injectables is an option to get your medication through a shot in your arm, for instance, once a month, once every 2 months, once every 3 months. And actually, there's a new formulation that's once every 6 months. And there's literature showing that because of the long half-lives of these medications, people stay well longer. And so, individuals no longer have to worry about taking a drug every day and can instead just come into the clinic and get a shot every once in a while, even just twice a year, and it can help keep them healthy. I bring this up here for a couple reasons. One is I don't want long-acting injectable medications to be confused with involuntary emergency intramuscular injections used during inpatient hospitalizations or used in the emergency room when individuals become agitated. I do think that our system, our healthcare system, our mental health system overutilizes things like restraints and seclusion and even these, here they're called code grays, where somebody has to be restrained and has to receive an injection of a medication to help calm them down. It should be a goal of every hospital to reduce the number of these administered, to zero if possible. But that's in contrast to long-acting injectable medications, which are also injectable and also in the muscle, but they last months. And the idea is that these medications actually help patients take more control of their lives, as opposed to giving up autonomy and be given medication administrations against their will. As for why they're underutilized here in the United States, again, compared to other countries, there's probably an issue of stigma and sort of the lack of infrastructure of available nursing staff. Um, but in any case, both clozapine and long-acting injectable medications have some interface with policy and with a law affecting their uptake in our population. So that wraps up what I had to say about medications. I wanted to touch on two other types of treatment. And one of them is kind of generically called interventional, which is a little odd because taking a drug is also an intervention. But interventional really refers to two types of treatment within mental health. And one is ketamine, and the other is TMS or other sort of neuromodulation techniques, right? Like that could also include TDCS or even ECT. So TMS specifically is transcranial magnetic stimulation. This is a diagram from the LA County Department of Mental Health website, and you see sort of the instrumentation, and you know, an individual sits in a chair, and there's this figure 8 shaped coil of that basically produces a magnetic field, and that magnetic field is able to create some current in targeted parts of the brain, and depending on what is being treated for in terms of symptomatology, different areas of the brain are stimulated with this magnet. And for people with psychosis, TMS is being used to treat auditory hallucinations in schizophrenia. And this is relatively new. It's not FDA approved yet, but it's being used off-label. And, you know, I myself have seen some success with this in very refractory cases, which makes me optimistic for the future. One really nice thing about TMS is that it's not a medication, so it's not going to have, you know, the same types of side effects, GI problems, or allergic responses. And it is FDA approved for treatment-resistant depression. However, some people are also going to experience headache or migraine, muscle twitching, and very, very rarely people actually may experience mania. But for psychotic spectrum disorders, it has a lot of promise when it comes to auditory hallucinations, and who knows, maybe in the future, visual hallucinations. Third category of treatments I'd like to talk about very briefly is psychedelic therapy. So psychedelic therapy seems like it's the hottest and newest thing out there right now. Many of you have probably heard about how it's the future of psychiatry and how transformative it is. How transformative it's been for either those who've experienced trauma and are living with PTSD, or who you know, are facing end-of-life issues, or even just have severe refractory depression. The two that are used most right now in psychiatry are psilocybin and MDMA. And I want to clarify a little bit of terminology. I really like this review from 2022. I have my my references at the end of the talk. But you know, MDMA is technically not a psychedelic. It's an entactogen, which means it increases empathy and connectedness to other people. And then psilocin is the active ingredient in psilocybin, and it is a formal psychedelic. And as I mentioned, you know, the areas of focus in psychiatry for use of psychedelics are trauma and PTSD, depression, cancer, and then, you know, there's an open question, could it be useful in psychosis? If you're wondering, you know, what a therapy session with a psychedelic agent might look like, especially organizations like MAPS, uh, really ask that it be a well planned and well-controlled environment. So the therapeutic environment is meant to have two therapists, and for patients to be very comfortable and to be guided through their experience in experiencing the emotional changes that correlate with you know, the biological changes in their brain that help them access feelings of, you know, greater spirituality, connectedness to others, better understanding of themselves, lots of positive feelings. And there's just a tremendous amount of research being done. You may be asking yourself, do psychedelics really work? Is this like a resurgence of something from the 50s and 60s and 70s? Most of the data out there has been very convincing. This is from a recent meta-analysis. Yep, actually May 2024, so earlier this month is when it came out. And in major depressive disorder, if you're not familiar with forest plots, basically if these shapes are to the left of this red line, that means that this study, and these are the different types of study, right? Placebo-controlled, positive drug-controlled. If the shape is to the left of the line, that means that this was superior to not having the treatment in terms of helping improve somebody's major depressive symptoms in that case. And in this case, I took off the label, but I think that this was, this was actually individuals dealing with anxiety and depression having to do with end-of-life issues, like for instance, having terminal cancer. And again, in this meta-analysis, the effect is really consistent. So if you're somebody with a psychotic disorder or experiencing psychotic symptoms, how could psychedelics possibly be useful to you? Don't psychedelics cause hallucinations? Don't they cause a disconnection from reality? But actually, there are some really interesting targets within psychosis for psychedelics. And those include empathy, social motivation, and social cognition. So you may remember from when I was describing some of the symptoms of psychosis, that cognition is a major issue. And a major subset of cognition that we don't tend to think about very much is social cognition. And so what is social cognition? Social cognition is our ability to read somebody else's body language, to read somebody's facial expression, to kind of try to interpret what they're thinking from a particular scenario that you just witnessed, or from finding out context about something and reading into somebody's facial expression as a result of that context. And it turns out that individuals, especially who have had longstanding psychosis, have a great deal of difficulty with this. And psychedelics can improve these specific aspects of cognition, including empathy, including what we call mentalizing, including social motivation and social cognition. And there is a study going on right here, actually, at UCLA, looking at MDMA for social cognition and ability for individuals with schizophrenia. Okay, so my last slide is about psychedelic treatment for psychosis and legal and regulatory issues. These are not necessarily specific to psychosis, but rather relevant to the field of psychiatry as a whole. I mean, some very basic questions, right? Like, is it legal to use a psychedelic as a part of therapy? And the answer is yes, in particular contexts, right? So for instance, psychedelics are currently Schedule 1 medications, which is the most tightly regulated class of medications by the United States government. However, given specific therapeutic uses, it can be used in these sort of like beneficial settings and be regarded as legal in that way. It tends to be quite state specific. For instance, Oregon, the host of our conference, has the most lenient policy and law when it comes to, I believe, psilocybin. It is not just legal from a medical standpoint like it is in several other states, including California, but it's actually just decriminalized entirely. If you ever have a chance to read up on the history of psychedelics and how they came to be made illegal, I think you'll find a fairly compelling story of how politicization of the law surrounding psychedelics affected the accessibility, it affected the access of people who might really benefit from these treatments for many decades. And I suspect that now that that's starting to change, we're going to be seeing some really exciting results from these medications, that they'll become more widespread. And I do hope and think that they can have real benefit for individuals who experience psychosis. So these are some of the papers that I make direct reference to, that I pulled some figures exactly from them. A lot of what I talked about, though, just comes from many years of treating people with psychosis and teaching about it to residents and students. And I want to thank the organizers again for having me, and welcome questions in the panel later.